Hello everyone, welcome to your lecture on chapters 11 and 12. We're going to discuss antepartum management. So we're first going to discuss the signs of pregnancy. There's three different signs that we look for to kind of confirm pregnancy exists. The first signs are presumptive signs. Now keep in mind these are subjective and reported by the patient. So these signs can also indicate that another condition is existing or a pathologic process. A lot of times these are signs and symptoms, and so just keep in mind it's subjective. Probable signs of pregnancy are objective and observed by the healthcare provider, but these don't necessarily confirm pregnancy. They're just observations, but again, there could be another cause. Positive signs of pregnancy, these are reassuring signs that pregnancy does exist and it does rule out other conditions. So presumptive signs of pregnancy include things like fatigue, and we see that around the 12-week mark or up to 12 weeks. Breast tenderness for 3 to 4 weeks. Nausea and vomiting 4 to 14 weeks. Amenorrhea, or absence of menstrual period, that's up to 4 weeks. Urinary frequency 6 to 12 weeks. And as you can see, a lot of these signs occur within the first trimester of pregnancy. Other presumptive signs include hyperpigmentation of the skin, and this is around the 16th week. Fetal movements are quickening, 16 to 20 weeks. Uterine enlargement, 7 to 12 weeks. And keep in mind the uterus, once it's at 12 weeks, it is no longer a pelvic organ. We are able to palpate the uterus. Breast enlargement, 6 weeks. So as you can see, these symptoms occur more into the second trimester or still within the first trimester. Okay, let's talk about probable signs. Braxton Hicks contractions. And we see those generally between 16 and 28 weeks. A positive pregnancy test. So an HCG, 4 to 12 weeks. Abdominal enlargement, 14 weeks. Ballottement, 16 to 28 weeks. Goodall sign is 5 weeks. Chadwick sign, about 6 to 8 weeks. And Hager sign 6 to 12 weeks. And we're going to talk about each of these signs coming up. So probable signs, Chadwick's is a bluish purple coloration of the vaginal mucosa and the cervix. This is typically observed when we visualize the cervix, such as during a pap smear, but we would not purposefully just do a pelvic exam just to check for this sign. Goodall sign is softening of the cervix, and again, we're going to palpate that when we do a vaginal exam. Hager sign is softening of the lower uterine segment of the isthmus. So this is like part of the cervix, okay? So kind of the middle part of the cervix. Probable signs of pregnancy, again, include Chadwick sign, Hager's, and Goodall's, and you can see that photographs on the right-hand side of the screen. That's actually a bluish colored cervix up top there. And then you can see where through vaginal exam, we're palpating probably the middle part or upper part of the cervical canal, and we're able to feel that softening of the cervix. So positive signs of pregnancy include ultrasound verification of an embryo or fetus. Generally, we see this 4 to 6 weeks. Fetal movement felt by the experienced clinician. So what we do is put our hands on the patient's abdomen and we actually feel for movements. We can feel at 20 weeks. It can be difficult, especially depending on the maternal habitus. If the patient's very thin, it's a lot easier to feel it rather than if they have a lot of extra subcutaneous tissue on their abdomen, so it might be a little bit more difficult. Auscultation of fetal heart tones via Doppler. 10 weeks is a little early to hear it. I mean, more like 11 to 12 weeks. And again, it really depends on the patient's body type, habitus, all that stuff. Okay, so is the following statement true or false? A positive pregnancy test is a positive sign of pregnancy. And the answer to that is false, okay? A positive sign of pregnancy would be like the ultrasound or the fetal Doppler. Okay, the uterus. So we're going to talk about the organs. It increases in size, weight, length, width, depth, volume, and overall capacity. Remember, the uterus is a muscle and it's going to expand to accommodate the growing fetus. The pear shape is ovoid, positive Hager sign we talked about already, enhanced uterine contractility, and Braxton Hicks contractions. Just keep in mind that every pregnant uterus contracts, and it can contract anywhere from that 16-week point. So even though the uterus contracts, it doesn't necessarily the patient is experiencing preterm labor. So they may just have contractions. And so when we talk about preterm labor later on in the term, we'll talk about that more. Ascent into the abdomen after the first 3 months. So again, that's about the 12-week mark, where the uterus is no longer a pelvic organ, but more going into the abdominal cavity. So the fundal height by 20 weeks gestation at the level of the umbilicus. So 20 centimeters is a reliable determination of gestational age until 36 weeks. Now, what I'll say about this is fundal height is very subjective. You have to be measuring it correctly from the symphysis pubis to the top of the fundus of the uterus. And the tape measure will correspond with the number of weeks the patient is. Okay, so again, 20 centimeters equals 20 weeks. If the patient has a lot of extra adipose tissue in the abdomen, this is not going to be a reliable method to measure fundal height. This is super important when it comes to the 3rd trimester and we start seeing growth restriction problems in the fetus. So any patient that has a larger BMI, a lot more abdominal tissue, we want to do an ultrasound to confirm growth. Okay, those patients are going to need a growth ultrasound, usually about every 4 weeks. 36 weeks, usually the patient is becoming very closer to term during this time, and so sometimes the fetus will drop into the pelvis, and so the fundal height will drop. So that's why it's up to 36 weeks. Okay, so we just talked about fundal height. They can have a 1 to 2 centimeter discrepancy. Okay, and that can be within normal limits. For example, if your patient is supposed to be 24 weeks and they measure 26, that's still within normal limits. However, if the patient is 24 weeks and they're measuring 20 weeks, okay, we have a problem with the growth. Okay, same thing if they're supposed to be 24 weeks and they're measuring 28 weeks. That's a lot larger than we would expect. So generally what we do is do an ultrasound for follow-up because we're worried about growth. And this is just another photo showing you fundal height. Okay, so breast changes. So there's an increase in size, nodularity, and preparation for lactation. Increase in the nipple size and they become more erect and pigmented. So they're going to be very dark, the areola. Estrogen stimulates the growth of the mammary ductal tissue. Progesterone promotes the growth of the lobes, lobules, and alveoli. Production of colostrum, so that's the antibody-rich yellow fluid that can be expressed after the 12th week. It does convert to mature milk after delivery, and it just varies from patient to patient. Some patients will be able to express colostrum, some patients will not be able to express colostrum, and it can vary pregnancy to pregnancy. Okay, so sometimes it can leak quite a bit of colostrum. This is normal, and we should just provide reassurance to the patient that it's normal. And this is just showing the pregnant woman. She's pretty much at capacity here and how it's pushing up on all the organs. And a lot of this causes discomforts of pregnancy, and it also can lead to some conditions that we would see in pregnancy that we normally wouldn't see because it gets triggered. So cervical changes. The cervix increases in mucus production, okay, and this is going to increase even more with each trimester. So sometimes a patient will come in and they'll say they have a lot of discharge. Is this normal? As long as it's discharge, okay, if it smells bad or they're itching or it's more watery, we kind of need to look into that a little bit more. Internal ballottement, 16 to 18 weeks. By a vaginal exam, we tap the cervix, the baby will rise up, and then the fetus will sink, and a gentle tap is felt on the finger. Okay, so again, we're not going to purposefully do a vaginal exam to check for this, but it's kind of a finding that we have if we do. Okay, so changes in body systems. This is really important to understand because this leads to some of the discomforts in pregnancy, and this is kind of what makes certain labs appear abnormal, but they are normal for pregnant women. Okay, so I want to emphasize that. Blood volume begins to increase by 6 weeks of gestation. Plasma volume increases 6 to 8 weeks until 32 weeks gestation. Okay, that kind of plateaus there. Red blood cell volume increases by about 20% to 30%. And what this does is it creates what's called a physiologic anemia. And that's why pregnant women have lower H&H, and this is within normal limits. So in your first and third trimester, a hemoglobin of 10 and a hematocrit of 32% is not uncommon. In the second trimester, it goes up a little bit. It can be 11% to 33%. So those are really the cutoffs in pregnancy. Now in a normal patient, that would be considered anemia, but not for pregnancy, because you have to account for this hemodilution effect, which causes this physiologic anemia. Okay, cardiovascular system changes. So you have that increase in blood volume. We talked about that. 50% above pre-pregnancy levels. And this is really Mother Nature's way of increasing blood volume in the pregnant patient to anticipate for blood loss at delivery. That's why the blood loss is normal if it's 500 mLs for a vaginal delivery, because we anticipate she's going to lose a little bit of blood, but we have this extra blood volume to kind of make up for it. Increase in cardiac output, increased venous return, and increased heart rate. And this is just really a slight increase in heart rate. This does not mean they're tachycardic, and that's normal. So just make sure you understand that. Slight decline in blood pressure until mid-pregnancy, then returning to pre-pregnancy levels. And this is usually early in the pregnancy. Okay, there's a lot of changes in the vascular system. And so oftentimes a patient's blood pressure will be lower. So you have to think about those patients that maybe have chronic hypertension that are on blood pressure medications. Sometimes we need to back off a little bit on those medications in the first trimester. Increase in the number of RBCs, plasma volume, RBCs leading to hemodilution. So we talked about physiologic anemia. Increase in iron demands. So fibrin, plasmin, fibrinogen levels, and some clotting factors. And this is what's going to put that patient in a hypercoagulable state. So because of all these clotting factors increasing, again, Mother Nature's way of protecting the pregnant patient from blood loss. But it does set the patient up for deep vein thrombosis and possibly pulmonary embolism. So we have to keep that in mind with this hypercoagulable state. Okay, other cardiovascular changes, about 50% more blood flow through the maternal kidneys, so increased metabolic waste. So a lot of times between this and the pressure of the uterus on the bladder, they have a lot more, they have to go to the bathroom a lot more frequently and urinate. Skin requires blood flow, so it dissipates heat. That's why pregnant women get so hot so easily. And they feel like it's really, really super hot, even though it's cold to everybody else. So blood flow to the breast increases 2 to 3 times, and it results in engorgement. And that's why women's breast tissue enlarges. pooling of blood in deep superficial veins, so legs, vulva, rectum. So a lot of times they get varicosities also in these regions, and also hemorrhoids. It's all due to the venous congestion and the pressure in the pelvis. So clotting factors, we kind of talked about this. All components increase during pregnancy. Iron supplementation is usually necessary, usually for most normal, healthy pregnant patients. A prenatal vitamin is going to contain the necessary iron that they need. So pregnancy, again, hypercoagulable state. So protection from hemorrhage during childbirth, increased risk of clotting, fibrinogen increases in anticipation of blood loss of delivery. So that's summing it up for you right there in that little chart. So when assessing a pregnant woman, which of the following would the nurse expect to find? And the answer to that is B, complaints of nausea. They actually have increased salivation and constipation. So the opposite of dry mouth and diarrhea, they should not have an increase in their blood pressure. Okay, so a little bit about maternal positions. As the growing uterus expands, we want to encourage women not to lay on their back. Okay, flat on their back is not good. They're compressing the great vessels, so the aorta and the vena cava. So when you have compression of the great vessels, this cuts off the blood supply. And it's going to cut off perfusion through the placenta as well. And most pregnant women can't really tolerate laying on their back very long. They're going to get lightheaded and dizzy because it does cut off oxygen and circulation to the brain as well. So we want them to lay in a side-lying position. And here it's kind of showing you the right side, but optimally for maximum placental perfusion, the left lateral side is the best side for the patient to lay in. So sleep positions. I just mentioned this, left lateral side. We talked about impeding blood vessels. Some studies suggest there's a higher risk of stillbirth when sleeping on the back after 28 weeks. Because again, you have a fairly large uterus. And so most pregnant women don't sleep on their back, but if they do, they should really sleep in an elevated position with pillows so they're not flat on their back. Okay, so gastrointestinal, so they do have increase in appetite if they're not nauseated. In the first trimester, most pregnant women are nauseated, or they have food aversions where they just don't feel like eating anything. So the appetite is definitely affected in the first trimester. It tends to improve in the second trimester where they're feeling more normal. Bleeding gums and gingivitis, sometimes excessive salivation, so we refer to that as ptyalism. Esophagus, reflux, acid, stomach contents, so heartburn, very, very common. And as you remember in that picture where you have the big belly is pushing up, it's pushing up on the stomach into the chest. So that's why a lot of women get heartburn because their gastroesophageal sphincter is weaker and it's closer to their mouth. So they're going to often have heartburn. The stomach and small intestines, decreased tone and motility of the GI tract due to elevated levels of progesterone. So it relaxes all the smooth muscle. And so this leads to constipation. Large intestine, small intestine takes longer to empty. So we just have to remember that. The liver and gallbladder, the liver is pushed upward and backward in the last trimester. The liver function can be altered. The gallbladder, emptying time prolonged. This does predispose women to gallstones. Okay, so we have had pregnant women have to have a cholecystectomy in pregnancy just because they have severe pain and gallstones. Okay, so keep that in mind with that. Respiratory adaptations, so breathing more diaphragmatic than abdominal due to increase in diaphragmatic excursion, chest circumference and tidal volume. So increase in oxygen consumption, congestion secondary to increased vascularity. So again, that's the estrogen at work, kind of causes everything to swell up and causes them to get nasal stuffiness. So pregnancy is a state of respiratory alkalosis. And the reason why is pregnant women breathe a little bit faster, a little bit deeper, and it can lead to hyperventilation. And so they're blowing off a lot of acid. Okay, so that's why they're in an alkalolytic state. The urinary system, so the bladder, first and third trimester, frequency and urgency of urination. Physical and hormonal causes lead to this. Third trimester, you have lightening. So that's where the dropping of the fetus into the pelvis. So the baby's literally dropping down onto the bladder, so it increases urinary frequency and urgency. Second trimester, you have decreased urgency, because remember, the uterus is more of an abdominal organ. It's not really sitting directly on the bladder like it is in the first and third trimester. So increased risk of UTI. So pregnant women are prone to bacteriuria. Okay, they just are because of all the changes. They may be asymptomatic. So that's why we run a urinalysis with a culture on women in the first trimester, because we want to be able to catch that UTI and we want to treat it. Because if they end up with a UTI, the urethra is very close to the vaginal opening. So they can have an ascending affection into the uterus, which can lead to preterm premature rupture of membranes or preterm labor. So we really get concerned about that, and we do want to treat the UTI. Now, if the pregnant woman comes back positive in her urine culture for group B strep, we're going to go ahead and treat her with antibiotics, but we're also going to treat her in labor for GBS, okay, because she's highly colonized with group B strep bacteria. So we don't even swab these women at 36 weeks. We just go ahead and treat them in labor. And when they're highly colonized, it grows back. So that's why it's not good enough to just treat them when they have it early in pregnancy. We always want to have to go back and treat them again in labor. Urinary flow is partially obstructed via the ureters, so they can get a condition called pyelonephrosis because the ureter is getting compressed, and this is mainly on the right side. The uterus likes to tilt to the right side, so it's kind of sitting on the ureter. Some women may have pain with this and discomfort because we'll go ahead and do an ultrasound on the kidney if they come in with flank pain, and we'll sometimes see pyelonephrosis. Pyelonephritis is different. This is an infection of the kidney that we want to treat. There's a stasis of urine, so that kind of sets them up more for the UTI, loss of bladder control, just due to the uterus sitting right on the bladder. And then pyelonephritis. Okay, so again, if we don't treat those UTIs, that infection can ascend into the kidneys, and then we've got a very sick patient. And pyelonephritis is very serious, and these women can end up with sepsis. So we want to make sure we treat these UTIs. The integumentary system, so there's a lot of skin changes in pregnancy. There's hyperpigmentation. In the face, we call this a mask of pregnancy. It's a melasma. It's kind of where they get this darkening in their cheeks on the sides of their face. Linea nigra is a dark line the woman gets from about the pubic bone up until the umbilicus and sometimes higher. They can get the varicosities. We talked about that just from all the venous congestion. Vascular spiders are common, palmar erythema. They can get pruritus. We call this PUPS. It's a very uncomfortable, itchy state of pregnancy. They usually develop it, thankfully, in the last trimester. But some women, they just can't tolerate it. And they usually might get a rash from scratching. Cholestasis of pregnancy, so this is also known as intrahepatic cholestasis of pregnancy, or ICP. This is a more serious skin condition in pregnancy just because it's related to high bile acids. And they have high bile acid salts, so when we run labs, that's what we see. We also will run LFTs because it can affect their liver, and they may have elevated liver enzymes. So really, this one usually does also occur in the third trimester of pregnancy. And the classic signs and symptoms of this is they have very itchy palms and feet. They have no rash typically. There's no rash evident, but they just have this itchiness. So we do run the labs. We can treat the patient with a medication called Actigol or Ursodiol. It's the same thing. This helps lower bile acids, but these patients require delivery at 37 weeks because there is a link with this disorder to a sudden stillbirth in the fetus. So we do deliver these patients early. Increase in hair and nail growth. So the hair grows very lush, the nails tend to grow really quickly, and they kind of develop a shine to their hair, so it's a very growing state of pregnancy, I should say. Connective tissue, so stretch marks, striae gravidum, that's a fancy name for stretch marks, and linea nigra, which is a dark line that you can see there. Now, stretch marks do not go away, unfortunately, but they do fade in color, so they go from kind of a darker color like you see there in the photo to more of a silvery appearance after delivery. Linea alba darkens to become linea nigra, and then again, symphysis pubis, the top of the fundus, and sometimes more. Abdominal changes, so rectus abdominal muscles during pregnancy, and you can see there the separation, and that's just caused from the uterus popping through. And usually the more pregnancies they have, the more they're going to have that separation. Okay, so this is called diastasis recti, and then they lose abdominal tone, and usually women who have cesarean deliveries, it's going to be worse because we're actually stretching those abdominal muscles apart to get to the uterus to get the baby out. And you guys may see that in clinical when you observe C-sections. And this is just showing you a frontal view and a side view of the growing uterus by weeks. So neurologic and musculoskeletal changes. So there's increase in body aches, especially with higher parity. A lot of pregnant women who they're on their second, third, fourth baby will come in with a lot of pelvic and back discomfort. And that's partially due to a hormone called relaxin. And that's literally what it does is it relaxes all the pelvic ligaments. Okay, low back pain, pelvic discomfort. Neurological system, so carpal tunnel is really common. A lot of times it kind of hits in the third trimester, late second, early third trimester, and the patient will often complain of like numbness and tingling in their fingers and sometimes pain. Classic really with this is it's worse at night, and they'll tell you that, and the treatment for this really is to tell them to put splints on their wrists. They can use ice packs for the discomfort, and they can elevate their hands at night on pillows. That should be helpful. But this is really due to all the extra fluid and the edema in the fingers, and that's what leads to carpal tunnel. This usually will go away right when they deliver. Shortly after they deliver, most women say it disappears. Bell's palsy is another condition. Affects cranial nerve 7. Okay, so they may have a drooping in the face, and sometimes pregnancy can just trigger this. It's usually caused by a virus. So if they have HSV, so herpes simplex virus, they may be more prone to this. It usually is something that's self-resolving that goes away. The biggest thing you want to teach them is sometimes they have trouble closing their eye, and they need to wear an eye patch until it resolves to protect the eye from debris and injury. Okay, musculoskeletal changes also involve softening and stretching of ligaments, holding sacroiliac joints and pubis symphysis. So this was cause of pelvic discomfort. Postural changes, so they have an increase in sway back and upper spine extension. So they have a forward shifting of the center of gravity. They have an increase in lumbosacral curve, so lordosis, and compensatory curve in the cervical dorsal area. So this what gives the pregnant women that waddling gait that they have, and also they have a higher risk for falls. So we have to warn women they should really wear appropriate shoes so they're not tripping or slipping, because they do have an increased risk to fall. And this is what Bell's palsy looks like. Okay, carpal tunnel syndrome we talked about already. I kind of talked about the signs and symptoms of this. They can also take Tylenol if they need to for the pain. But again, so numbness. Sometimes I can't even hold objects. Like I had a patient once that said she dropped a glass because her fingers were so numb. So again, there's your management for that. Endocrine system, so the thyroid gland, there is slight enlargement, increased activity because there's an increase in BMR. The pituitary gland, there's enlargement, decrease in TSH, growth hormone, inhibition of FSH and LH, because remember this shuts down the menstrual cycle completely when the patient's pregnant. There is an increase in prolactin. Again, the hormone that is responsible for milk production. Okay, MSH, gradual increase in oxytocin with fetal maturation. Okay, and so these levels tend to be low in pregnancy because, again, this induces labor. So it's going to increase as she gets closer to labor. And remember, oxytocin is a hormone responsible for milk letdown. The pancreas, insulin resistance due to HPL and other hormones such as progesterone and cortisol, and that's what sets a woman up for gestational diabetes, which we'll talk about in a lecture coming up. The adrenal glands, increase in cortisol and aldosterone secretion. Prostaglandin secretion, again, this is going to occur later on in the pregnancy more because this helps prime the cervix for labor. Placental secretion, again, we talked about those hormones, HCG, HPL, relaxin, progesterone, and estrogen. Is the following statement true or false? Oxytocin is a hormone secreted by the anterior pituitary gland. And the answer to that is false. Okay, it's secreted by the posterior pituitary. Okay, so these are the healthy weight gain guidelines for pregnancy. We talked a moment ago in the other lecture about nutrition. So really important for women to not gain too much weight, okay? So if they have a healthy weight, okay, so a normal BMI, they want to gain no more than 25 to 35 pounds, okay? If the BMI is less than 19.8, they should put on more weight because they're typically underweight, okay? 28 to 40 pounds. A BMI over 25, they should limit to 15 to 25 pounds, okay? So this is pretty standard weight gain parameters. It's not perfect, but some women, they just tend to gain more weight, and some women tend to gain less weight. But we want to try to make sure they don't gain too much weight, because this is going to lead to a larger fetus and set them up for more birth complications, and the neonate will have complications as well if they get too large. Okay, so again, nutrition, we kind of talked about this in the other lecture, but a lot of client education. We use the USDA food guide, My Plate. Cultural variations, so we have to take in cultural considerations. Some patients are lactose intolerant. They should not go on a gluten-free diet. We talked about that. Vegetarianism, they want to make sure that they get enough protein in their diet, and we need to monitor for signs of pica. This usually indicates a low iron or an anemia, and this is kind of where they crave inedible items, like things like cornstarch, even laundry soap, laundry detergent, dirt, clay, ice. Even ice is another form of pica. Okay, so we have to kind of take in consideration the psychological aspects and maternal emotional responses. So ambivalence is a state of mixed feelings about impending arrival of the baby. So, I mean, kind of depending on the circumstances of the pregnancy. So maybe this is a complete surprise. They weren't expecting to get pregnant, or unplanned pregnancy, or, maybe they didn't want to get pregnant and it was an accident type of thing. So we have to take into that, it's going to take them a while to kind of adjust to it and to kind of determine what's going on. Introversion is a focus on her own body and changes with pregnancy. So this is common. Okay, women sometimes are very accepting to changes in pregnancy. Other times, it can be hard for them to accept the changes, okay, because their body is changing and looking different. Acceptance, how the woman thinks and feels about the pregnancy once discovered, and then mood swings. These are often as a result of hormonal influence. Okay, so maternal role tasks. So we have four of them: ensuring safe passage throughout the pregnancy and birth, seeking acceptance of the infant by others, seeking acceptance of the self, a maternal role, binding in is what we refer that to, and then learning to give of oneself. Okay, because especially if women, it's their first baby, they may be just used to being with their partner. And so they don't have to really think about anybody else. They only had to worry about themselves and kind of what they're doing in their life and what they want to do. So now that they're pregnant and they're having a baby, they have to factor in another person. Okay, pregnancy and sexuality. So there's numerous changes, possibly stressing sexual relationship, changes in sexual desire with each trimester. They don't really want to have intercourse the first trimester. They don't feel good. And same thing third trimester. They feel heavy, they feel big, they have this big belly. So sometimes intercourse may be difficult for a lot of women. But the second trimester is usually the optimal time where they feel well and most likely to desire that. Sexual health is linked to self-image, okay, because sometimes they don't feel attractive. Generally safe in pregnancy unless high-risk conditions exist. And there are contraindications to sexual intercourse that they absolutely should not engage. One of those is placenta previa, risk of bleeding, anything that's going to cause a preterm delivery or bleeding condition. We do not want them to do that. Okay, is the following statement true or false? Ambivalence is a normal response during the first trimester of pregnancy. If you thought true, you are correct. Okay, so pregnancy and the partner. So there's a family-centered emphasis. The partner's reaction to pregnancy and change. Kuvad syndrome, the partner may experience signs and symptoms of pregnancy. We've kind of all heard those stories where the partner has morning sickness. Well, it really is a thing. It does happen sometimes. Ambivalence, acceptance of roles. So second trimester, usually that occurs. They achieve that. Preparation for reality of a new role usually occurs in the third trimester. So pregnancy and siblings. Age-dependent reaction. Okay, so depending on the child's age, they may feel differently about the pregnancy. Some may be very accepting of a new sibling. Others, usually if they're the toddler stage, they don't really understand and they kind of want the baby to go away. So there's different reactions. Sibling rivalry with the introduction of new infant, sibling preparation imperative. They just have to kind of know if they understand. It's not unusual for the child, especially if they're a toddler age, to start reverting backwards, like they start getting really needy again. And sometimes they may wet their pants. They may do other things. They may want to breastfeed again. They may want to go back to sucking on a bottle. So those kinds of things occur with siblings. Okay, so goals of preconception care, and I can't emphasize enough preconception care. A lot of patients don't get it. Okay, they end up pregnant, and so we're dealing with things after the fact. So we want to promote health and well-being of a woman and her partner before pregnancy. I mean, that includes getting a handle on chronic conditions prior to pregnancy, like diabetes and hypertension, obesity. We want them to get to a healthy weight before they conceive. Because they're going to have the healthiest outcomes if they get control over these things. Identify and modify biomedical, behavioral, and social risks to a woman's health or pregnancy outcome through prevention and management intervention. Because if they don't, there could be lifelong effects to the offspring if they don't control these conditions. And one of them that's huge is like maternal diabetes and offspring. Okay, childhood obesity is becoming a big problem, and so is diabetes, early onset of type 2 in children. And so if women control their diabetes, if they get themselves down to a healthy A1C, and that's usually around 6, okay, or less, this is going to really improve the outcomes for the fetus. So it's really imperative we talk to patients about preconception care. Antepartum care is to ensure pregnancy ends in the birth of a healthy infant without impairing the health of the mother. Important part of prenatal care. Okay, this is really, really important. So the very first prenatal visit, we establish a trusting relationship with the patient. And this can be difficult sometimes if the practice has multiple providers. Sometimes the patient never sees the same person again. And so it's hard to develop that kind of relationship. If you have a smaller practice, it's a lot easier because they're seeing the same people. Focus on education and overall wellness. Detection and prevention of patients' problems, of potential problems for the patient. Comprehensive health history, physical exam, and laboratory tests. So we want to make sure that we're giving anticipatory guidance, kind of what we're doing, how we're going to manage their care, and what they can expect. We want to know their immunization status. So underlying medical conditions, prior pregnancy history, delivery types and complications. This is particularly important if you have a patient with a prior C-section and now they're coming in telling you they want to attempt a vaginal birth. So a lot of times we have to have the operative report showing what type of scar they had, because as long as they had a low transverse scar and you have a provider that's willing to do VBACs, that's probably the safest route for the patient. If they have a vertical scar or a classical incision or a T incision, they're typically not a candidate for a VBAC because they have a higher risk of uterine rupture. So VBAC is vaginal birth after cesarean. VBACs usually have delivered vaginally before and had a C-section, and now they want another vaginal delivery. Whereas a TOLAC, usually they're a trial of labor after cesarean, so they've never actually had a vaginal delivery, but they're doing a trial. Sexuality and sexual practices, so we need to talk to them about that. Do they have multiple partners? Do they use protection? Have they been exposed possibly to STIs? Because we do need to detect and treat those if they have, because it can be passed on to the fetus. Nutritional status, what's their diet like, what's their BMI, and when we're determining the BMI, we do a pre-pregnancy BMI. Lifestyle practices, psychosocial issues, do they have habits? Are they using drugs? What medications are they taking? All of those kinds of things. With psychosocial also, do they have a history of depression? This is going to be very important, or anxiety. This will become very important when they deliver, because are they at higher risk for postpartum mood disorders? And then their support system. Do they have a good support? Is their partner supportive? All of those kinds of things are important to consider. Reason for seeking care, usually they're going to tell you I'm pregnant, okay? That's going to be their chief complaint usually. They suspect pregnancy. We want to establish the date of their last menstrual period. Some women, again, don't know the exact date, but if we can get a rough estimate, they're going to get dated by ultrasound again if they don't know. Signs and symptoms of pregnancy, we're going to take a note of that. Urine or blood test for HCG. Past medical, surgical, and personal history. Use of contraception. It's important to know, were they on any birth control method when they became pregnant? Women's reproductive history. So menstrual, obstetric, gynecologic history, like when was their last pap smear? Okay, some women don't know, they're not sure, they went to a different provider, we can't always get the records. So typically if they don't know or we don't have results, we're going to just do another one, because we want to do that cervical cancer screen. That's really super important in pregnancy. Okay, we talked about date of last menstrual period. So if you do have the date and it's an accurate date, you can calculate the estimated date of delivery or expected date of birth. by Nagel's rule. So you're going to use the first day of the last normal menstrual period, subtract 3 months, add 7 days, and add a year if you need to. So gestational birth calculator can also be used, or a wheel. A lot of times there's an app nowadays that we can use to just plug in the numbers and it tells us the estimated date of delivery. Ultrasound is the best method of dating a pregnancy of greater than 7 days discrepancy. So again, we want to know the obstetric history. So it's important to establish gravida and parity. Okay, so gravida, first pregnancy, they're a prima gravida. A gravida 2 is a segunda gravida, second pregnancy, etc. Okay, so we often refer to this as prima para after one birth, a pregnancy at least 20 weeks. Okay, so para is kind of like the offspring. What was the result of the pregnancy? Multipara, 2 or more pregnancies resulting in variable offspring. Okay, so this is a multiparous woman. Nullipara is they've had no viable offspring, so para 0. Okay, there is a quiz in the modules that kind of review the gravida parity. So if you want to practice that, go ahead and go into the modules and take that practice quiz. It's not worth any points, but it'll kind of help you understand more. So GT-PAL, so it breaks it down even further. And again, in the modules, the quiz will go over this as well. So gravida is the G, the current pregnancy, okay? So how many has she had, okay? So think of gravida is like the tally of pregnancies, okay? So now if they had multiples, that only counts as one pregnancy under G, okay? Term is a term birth, number of term pregnancies ending greater than 37 weeks gestation, okay? Preterm, the number of preterm pregnancies ending greater than 20 weeks or viability but before completion of 37 weeks. Abortion is the number of pregnancies ending before 20 weeks or viability. And living children is the number of children currently living. However, if they do have a live birth, okay, and the child subsequently passes away, that's still going to count as a living because the child was living at birth, okay? The only exception to this is if they have an early delivery where the child passes shortly after, then that wouldn't count. Okay, is the following statement true or false? A multipara refers to a woman who is pregnant for the first time. And if you chose false, you're correct. That would be referred to as a primipara if they're pregnant for the first time. So physical examination, it's important to get vital signs. We check that at every prenatal visit. Blood pressure, pulse, okay, all those things to ensure that it's normal, okay. We're doing a head-to-toe assessment. Usually this is going to be the first prenatal visit or when they come back at their 12-week visit. So head and neck, chest, abdominal, including fundal height, if appropriate, over 12 weeks. Extremities. We're going to also be doing a pelvic exam on these patients, and this is if they are due for a PAP, okay, or they're due for a pelvic exam. We don't necessarily do a PAP every time, only if they're due for one, but we may check inside just to make sure that there's nothing else going on. We call that a bimanual examination. And that's where we might feel for that Hager sign, and we may see the Chadwicks if we're looking at the cervix, okay? So we'll look for those findings in a pelvic. Laboratory tests. So these are the prenatal labs that we do at the beginning of the pregnancy. All pregnant women get a prenatal panel. Okay, so urinalysis, and we kind of talked a little bit earlier about why we collect that, because we check for UTI. Complete blood count, because we want to know if they're anemic. Blood typing. We need to know mom's blood type, because if she's blood type O, we will test the baby for blood type, because we worry about ABO incompatibility if the baby is A or B or AB. We're checking an RH factor. Okay, if mom's RH negative, The baby will be tested at birth to determine if they're Rh positive, because we have that concern about Rh incompatibility and isoimmunization, and that's why women will receive RhoGAM in pregnancy if they're Rh negative. And usually routinely they'll get RhoGAM at 28 weeks. And the reason why is RhoGAM's good for 12 weeks. Rubella titer, we want to make sure that they're immune to germ and measles. If they're non-immune or equivocal in the lab result, they're going to require an MMR after delivery. Now, we don't give the measles, mumps, and rubella vaccine during pregnancy because it's a live vaccine. We're going to check for chickenpox status. We'll do a varicella titer. Again, if they're non-immune, they're going to need a vaccine after delivery because this is also a live vaccine. Hepatitis B surface antigen will tell us if they have hepatitis B infection. We do check for hepatitis C antibody now in all pregnancies. HIV, we're going to check for VDRL or RPR. This checks for syphilis. Now, if you have a positive RPR, you're going to send the patient back for a confirmatory test. The RPR can come back positive from other things, like Lyme's disease is one that it can come back positive. So we always want to do that confirmatory test for syphilis. That's going to be checked 3 times in the pregnancy. Here in the state of Nevada, we have a high rate of syphilis. So they're going to get it initially at the 12-week labs or first trimester labs, and during the second trimester when we do the diabetes screening, and then again on admission to labor and delivery. Cervical smear, we talked about the Pap. If they're due for it, usually that's going to be every 3 to 5 years if they've had normal Pap smears, starting at the age of 21. And then, of course, ultrasound. And they're going to get about 3 or 4 ultrasounds if they're healthy during the pregnancy. Antepartum assessment and care, so subsequent assessment. So the schedule is really pretty much for all uncomplicated pregnancies. Conception to 28 weeks are going to be seen every 4 weeks. 29 to 36 weeks are going to be seen every 2 weeks. And then 37 weeks to birth, they're seen weekly. Assessment of fetal well-being. So this is through ultrasound. Early confirmation at the 12-week visit, we're going to do genetic screening. Again, checking for the nuchal translucency or NT, presence or absence of nasal bone, and just an overall view of the fetus. Now, a lot of major anomalies can be detected on the 12-week ultrasound, but we don't do the full scan, anatomy scan or detailed scan until 18 to 20 weeks. And the reason for that is because some of the structures, especially in the brain, cannot be visualized. They just can't be seen yet because of development. So if we do it any earlier than 18 weeks, we're not going to be able to see anything. So usually this is a time frame that we do the anatomy scan. Doppler flow studies is needed, so we check umbilical artery Dopplers to check the blood flow, especially if we have a fetus that's showing interuterine growth restriction. We also call that IUGR. So it just means that they're not growing at the rate that they should be growing. Alpha fetoprotein analysis, so this is the MSAFP that we check for spina bifida. And again, this test is done 16 to 21 weeks. We're also going to check marker screening tests, and again, that goes along with that 12-week ultrasound for genetic abnormalities, and then amniocentesis to follow up if they have abnormal screening. Okay, and this is a picture of an ultrasound. The ultrasound's very good nowadays. We can see a lot of things. You can see there that little baby's waving, "Hi, Mom." And this is kind of the whole procedure that they would go through for an amniocentesis. It's done under ultrasound guidance. Okay, a spinal needle is placed into the abdominal wall, and it's put in a big pocket of fluid where there's no fetal parts, cord, or placenta. And then they just collect a sample of the fluid into a syringe and send it for analysis. Is the following statement true or false? A woman who is 24 weeks pregnant would arrange for a follow-up visit every 2 weeks. If you chose false, you're correct. They should come back in 4 weeks at 28 weeks. Okay, so first trimester discomforts. We kind of talked a little bit about this earlier. Urinary frequency or incontinence. Okay, it's not uncommon for them to leak a little bit of urine. Okay, sometimes they worry their water broke. Usually not this early. That's more kind of in the third trimester where they have that bladder compression, frequency, and incontinence. Fatigue. We want to encourage women to get a lot of rest. They're going to need it. They're tired, okay, especially in the first trimester. Nausea and vomiting. And then again, we want to teach women to eat very bland crackers are good, dry saltine crackers before they even get up. So if they keep a supply at their bedside, that's really good because that can help ward off some of that nausea and vomiting. They can try Unisom along with vitamin B6. They can take 25 to 50 milligrams of that vitamin B6 with the Unisom up to 3 times a day, but we do have to warn them they can get tired. There is a prescription form of that that's more extended release called Diclegis. Some insurances don't cover it though, so they can try the Unisom of vitamin B6. We try to avoid giving them any antiemetics in the first trimester, although if it's very severe, we may give them some Zofran. We've tried Phenergan, Reglan, Vistaril. Those are some of the choices of anti-nausea medications that we've used. If it's very severe, they may have hyperemesis gravidarum, so that's a whole nother story, and we'll talk about that when we talk about antepartum complications. Breast tenderness, they should probably just wear kind of a nice bra that's going to give them a lot of support. Constipation, again, increased fluids and fiber in their diet, nasal stuffiness, bleeding gums, epistaxis or bloody nose, cravings, and then leukorrhea, which is the increased discharge. Okay, second trimester, again, backache. And we want to be sure we differentiate this from preterm labor because a lot of times they may present with backache. So a lot of times with preterm labor, they're going to more report that it's kind of a radiation from the back to the front and their belly might get tight. They may complain of pelvic pressure. So those are the kinds of things that we want to pay attention to if they're complaining about that. But generally just back discomfort, they can use a heating pad. They should try to do regular exercises to help with that. Varicosities in the vulva and legs, okay, they can wear what's called a V-strap support that kind of helps with varicosities, especially in the vulvar region. Hemorrhoids, again, lots of fluids, fiber. If they need to use like preparation H, they can use that. If they need something a little stronger, a lot of times we'll prescribe them some Anusol, prescription strength to help with that. They may have flatulence and bloating, and again, heartburn is really common. In the third trimester, they may get return of first trimester discomfort, shortness of breath and dyspnea, heartburn and indigestion, dependent edema. Edema is pretty normal as long as their blood pressure is normal. So it's not really a criteria we use anymore for hypertension and pregnancy. And then we'll talk about that when we talk about that complication. Braxton Hicks contractions. So again, they're just really contractions that really don't do anything. So while assessing a woman at 18 weeks gestation, which of the following would the nurse report as unusual? And if you chose urinary frequency, you were correct. Remember, this is going to be more likely in the first and third trimester. So sleep and rest is important, especially when they're fatigued. Sexual activity and sexuality, and usually it's perfectly fine in pregnancy as long as no complications. Also for fatigue, we want to encourage exercise. Sometimes they can really combat fatigue if they get regular exercise. Employment, so we kind of want to take into consideration, do they have any exposures to radiation or chemicals or anything like that? Travel is generally safe in pregnancy as long as they're moving around. The biggest concern with travel is blood clots. So we want to make sure that they're getting up at least every hour to walk around, especially if they take a long trip. And also kind of checking if they fly with the airlines because some airlines don't let them fly past a certain gestation. So they always want to check that. Immunization and medications. Okay, so we want to review those with the patient. So perinatal education, so childbirth education is important. So there's different methods that they can participate. So Lamaze, it's a psychoprophylactic method that focuses on breathing and relaxation techniques. The Bradley method is a partner coach childbirth method. It focuses on exercise and slow controlled abdominal breathing. The Dick Reed method is a natural childbirth method that focuses on fear reduction via knowledge and abdominal breathing techniques. So options for birth settings. So most women, especially in our area, choose hospitals for delivery room with a delivering room and a birthing suite. There are birth centers. State of Nevada, I think there might be one in Las Vegas. I'm not really sure. I think there is one. But for the most part, in the state of Nevada, we don't have birth centers, which is a bummer because they're nice. Home birth is an option for care providers, so obstetrician, midwives, doulas. Doulas are usually just labor support only. There's a lot of good studies that link doulas to positive birth outcomes. Less epidurals and less C-sections, less need for pain medication. So there are really good studies on this, but again, doulas are only there for labor support. They're not supposed to be there to speak for the patient. I've had some doulas that aren't so good and they interfere. So just be aware of that. And if you guys have any questions at all, I'll be available by email. So please reach out to me if you need anything and I will get back to you. Have a great day.